thank you for joining us this evening for our first OTAC case-based webinar. Many of you may be familiar, the OTAC is the training course and program that is run across New South Wales around opioid pharmacotherapies, as well as an accreditation mechanism for those that are prescribers. But we welcome both prescribers and non-prescribers alike, anyone that has an interest in opioid treatment. And tonight we have Dr. Tremonti, who will be leading this session along with Dr. Sharon Reid. Chris is an addiction specialist and clinical pharmacologist at St. Vincent's Drug and Alcohol, and in his limited spare time, he is also doing a PhD. And so if anyone would like to ask questions about Chris and his PhD thereafter, by all means. And Sharon Reid is one of the medical officers at Drug Health Services Sydney Local Health District, and also works with myself at the University of Sydney. Before we go any further though, I would like to make an acknowledgement of country. I would like to acknowledge and welcome the traditional custodians on the lands which everyone meets this evening, and to recognise the continued connection to land, waters and culture. And I'd also like to pay respects to elders past, present and emerging, wherever we are based this evening. One slide that I always like preparing is registration numbers, because it's always really interesting to see where people are coming from tonight. We had about 150 registrations and we've got about 60 people online. Inevitably, not everyone turns up, but this just gives you a rough idea of people who had an interest in this session. I think there were about 50% within metro areas, another 35% in regional, and we've had about 15–16% of interest from interstate areas. So welcome to everyone from wherever you might be this evening. And I will hand over to Sharon, who will introduce the webinar.
Hi everybody, very big welcome to our case-based webinar tonight. I just want to give you a bit of an overview of the format and how we run the webinars for those particularly that haven't been before. So essentially we're aiming to provide a comfortable, beneficial and valuable learning experience for OAT prescribers across New South Wales. It's mainly around case-based discussion with a little bit of didactic, but mostly case-based discussion. So we rely a lot on your questions, and ideally you could post those to the chat. Potentially, if it's a really burning question, you can raise your hand and we'll try and answer it. We try and be really tight with time, starting at 6, finish by 7. At the end of the course, participants will be emailed some documents by Daniel, including a certificate of participation and any relevant resources we can think of to send you. And if you want to find out more about the webinars and get access to the webinar resources, you can go to the OTAC website listed on this slide here. And as Daniel said, we've got a whole range of different experienced facilitators involved in these webinars across New South Wales. Next slide, Daniel. Yeah, thank you. So just some housekeeping. Keep yourself on mute unless you're actually talking. Put your video on if possible, because it's good to see people. We encourage you to keep a pen and paper and a notepad so you can jot down some points or questions you want to ask or some ideas. If you do want to ask a question, as I said, you can raise your hand or type something in the chat. If you do get on and talk via Zoom, could you please introduce yourself? This webinar, by the way, will be recorded for people that can't get along, and also for you to have a look at afterwards, accessible via the OTAC website. So be mindful that it is recorded, so be very careful not to reveal any identifying information about any cases or anything you don't think is appropriate to share across the group. Please always be polite and considerate of your colleagues, and could you please declare to the organiser if you think you've got any conflict of interest prohibiting your attendance at these webinars. In the past, I think we've had the odd pharmaceutical rep turn up and we're not quite sure whether that's appropriate to have them along. So anyway, about the case discussions, we allow about 8 minutes per case. This includes thinking time. And also we have these brief before and after discussion polls where you give your opinion about a question that's posed to you, and we compare your responses before and after the case discussion. So please be ready with your pen and paper to take notes so you know how to complete the poll. Is there another slide? That's it. Okay, so it's over to Chris Tremonti to begin with the cases. Thanks very much, Chris.
Thank you, Sharon, and thank you, Dan, and thanks to everybody for coming along today. It's wonderful to have an extensive audience. Some of you I know and some of you I don't, so that's wonderful. So I thought I'd begin with this case that was reasonably recent. So this was last year, a 65-year-old female who presented to the ED with shortness of breath, lethargy, and vomiting. Now, this lady had stage 4 diffuse large B-cell lymphoma that was diagnosed late in 2021 and had received a previous course of R-CHOP, which is a combination of chemotherapeutic agents. So they're all listed there that you don't need to know all of that, all of those drugs and all of those interactions. I'm sure some of you do. She'd had Hep C before, but she was RNA negative now, which meant she had cleared it, which is great. She'd had chronic bronchitis with previous aspiration pneumonia. She had a bit of LV dilation, which but still had a preserved ejection fraction. And when she came in, she had a mildly elevated white cell count and a CRP. But her chest X-ray showed a left pleural effusion with left lower lobe collapsing consolidation, and she was diagnosed with a severe community-acquired pneumonia. Just in terms of substances, I should also point out this lady was a lady from one of the very wealthy, shall I say, eastern suburbs of Sydney, so just once again demonstrating that substance dependence really does cross all socioeconomic barriers. Obviously, we see a bit more opioid dependence, perhaps in lower socioeconomic, but it's still there are those who are in as I say, elite, wealthy socioeconomic positions that have previous heroin dependence. But she was on methadone daily. She picked it up weekly, and she didn't use any other opioids, and had been doing so for really, I think it was about 33 years. Was how long she was on that. She'd had previous alcohol use disorder. She was reporting she drank sort of about 4 standard drinks every second day. She was a smoker. That was probably part of the reason why she had chronic bronchitis and really was going to probably limit her life expectancy much more than anything else there. She also was prescribed a little bit of diazepam, but that was reviewed on safe scripts and there were no aberrant behaviours or anything. So we were asked to see her because they'd done an ECG and her QT was 510. And so, of course, the methadone was questioned as to what we should do about her methadone and methadone dosing. So she'd been on it for 33 years, as I say. She was very happy on this. She'd had no previous syncopes or arrhythmias, but had also been started on a number of other medications while she was in hospital. There's a couple there that I will draw your attention to, which is azithromycin and furosemide as well. So I guess we want to make these sessions interactive. I think, Dan, you're going to run a poll now, and I'd be interested to see what people want to do. So what do we want to do? Do we want to cease her methadone immediately? Do we want to trial an alternative opioid such as oxycodone? Should we switch her to Bup? Should we reduce and cease her methadone? Should we do nothing? I'm very interested to hear what people would do. I understand many people here probably work in community-based settings, but as I say, and I appreciate that this is an inpatient, perhaps with a bit more clinical acuity to it, but nonetheless, very interested to hear what people want to do.
Wonderful. We'll leave it going for a little bit longer. We've got about 60% who have completed the poll.
Right.
In the interim, while we're waiting for a couple of people to just finish that off, a quick question from Janelle on the chat.
Yeah, sure.
Her question was just around if there is a monthly dose of buprenorphine 8 milligrams. So I'm assuming that's referring to depot versions. So in other words, like a 32 milligram monthly.
Oh, I assume what you're asking is because there's no equivalent. So there's the 8 milligram weekly, which is an equivalent sublingual dose of less than 6 milligrams. And so there's no monthly equivalent of that. So the smallest monthly dose we have is the 64 milligrams. I'm not aware of a 32 milligram sort of monthly, which would kind of be the equivalent. I don't know if that's something that's being worked on or trialed. It is, I understand that it can at times be a bit frustrating when you're potentially wanting to transition somebody on low dose, or potentially when you're wanting to get somebody off, you know, who's on a low dose. I tend to just stagger the other agents we have available. So I might push a 64 milligram patient out. I've pushed them out to, you know, 8-week sort of injections. And so not something that you'll see on the product information or anything like that, but certainly something I've done before.
A couple of people in the chat have said that they've done half of 64s as well, which
actually sort of injecting half of the
interesting.
I have not seen that. I can't honestly. I can't comment on that one.
No, that's all good. Interesting nonetheless, though, to hear that.
All right, shall we move on?
Yes. And I'll just quickly share that result. So we have most people saying from methadone to buprenorphine in this
well, that's because everybody knows. No, I'm guessing people think I've got an axe to grind here. So okay, transition of methadone to buprenorphine, fair enough. Do nothing I saw was I'm pleased to see that do nothing got a fifth of the vote and came second, and we'll talk about that in a moment. So the patient eventually, I say eventually, they were reasonably hesitant at first. I will also add that the patient did eventually, you know, go to intensive care for some non-invasive ventilation. So they were not tubed or anything like that. But they, you know, and certainly in areas like intensive care, they can get quite nervous about QT prolongation. And I've certainly been aware of, you know, ICUs or patients have been on the cardiology where they just stopped it. Which is perhaps, I don't know necessarily the best way forward. But anyway, so eventually we tried to do a microdose transfer, but I guess before we progress, we've got to talk about what is a microdose transfer. So this is what's going to be on my tombstone, I think. So I was born in May. I'll be dying the day after my PhD is finally done, and all I ever did was microdose. So as many of you know, this trial has completed recruiting. Hooray! It's registered on ANZ CTR, and it is microdosing with buprenorphine to transfer from methadone to buprenorphine. I have talked at length about microdosing in a number of settings, and I'm not going to. I'm always happy to talk about it. I don't want to waylay the entire talk today about microdosing, of course, but I guess we kind of have to at least mention it. This was a prospective multi-center non-randomized study. So when I say non-randomized, patients actually got to choose which arm they wanted to be in. So they needed to be on methadone for at least 5 days and wishing to switch to buprenorphine. And a primary outcome really was a success in terms of transfer to buprenorphine. And then we measured a few other things along the way. I'm grateful to all of these sites that were involved. I'm grateful to people beyond these sites who still provided wonderful input. Simon Holiday up in Taree, and Michael Levi down in the ACT, and other sites who've said to me, "Oh, we would have loved to be involved," or "We didn't know about it." So apologies to anybody who missed out, but also thanks to all of these sites that were involved. As you can see, it is a little bit Sydney metro centric, so apologies to those in more regional and rural areas. This is the microdosing protocol that we used. So basically, X is dose of methadone. So in our ladies, 50 milligrams, and then we would halve it on day 6 and quarter it on day 7, while the buprenorphine dose is slowly up titrated. As for the standard of care, so current standard of care for switching over between methadone and buprenorphine is, as per the New South Wales Clinical Guidelines of Depends 2018. Now, I should point out that without going into too much detail, there will be some updates about this, and it's expected that microdosing and bridging will be in the new versions of the Now, I forget which one it is. I think they're going to put out a new version of the depot guidelines or the main guidelines. It will be in one of them. So watch this space. But nonetheless, this is the current standard of care as per the current guidelines. So these numbers are already a bit out of date because I discovered there were 2 participants who did the study that got recruited to the site that I wasn't even aware of. So it will actually be 117 should be the final number, which I am indebted to many people for that. And as you can see, yeah, there was a higher average methadone dose in the microdosing arm as opposed to standard of care for obvious reasons, but because most of the time patients were on lower doses and wanted to do it, you know, had dropped down to switch over or so forth. They had a success rate was similar between the two. There was a we did cows quite a lot, which is the clinical opioid withdrawal scale. We did that every day, sorry, and around a fifth of patients got to 13, which would be considered moderate withdrawal. SOWS is the short opioid withdrawal scale, so that's not the subjective opioid withdrawal score. It's a short opioid withdrawal score, which we used because we wanted to try and facilitate ambulatory transfers, and we knew that keeping patients around for an hour or two afterwards to keep measuring cows was going to be a disaster. So this is actually a measure of symptoms over the previous 24 hours. So, and is probably a bit more sensitive than cows. The majority of transfers were also ambulatory, which is really how this project all began. I really was hoping we could find a way to help people that wanted to switch over. And then, of course, obviously, the depots came along, and that's escalated that. I do also want to add what I'm doing is not groundbreaking. You know, I think there is a fair bit of anxiety around methadone buprenorphine transfers, but the literature shows that the majority of patients will transfer successfully, and whether that's using stop and start, switching straight over, 7-day fixed regimens. You know, I can't speak to the clinical experiences of each of them. But you know, they're reasonably successful. So we'll go back to the cases. So what was I going to say? We've got this lady. She's been started on some QT medications. I noticed that there was a mention in the chat here that there was we could switch them over to Doxy. And look, I guess this is something I'm trying to emphasize here as well. So the patient consented. We gave her 200 micrograms of buprenorphine. She didn't really have a lot in the way of her cows and sows. They were pretty minimal, but she then declined further doses. She said she felt sick and she just wanted to stay on methadone. And I present this case not, you know, as I say, I don't believe that this is precipitated withdrawal or anything like that. I think this is a case of we get patients who really are enthusiastic to switch over to buprenorphine, and they see that getting onto the depot is a benefit to them because they want to only attend dosing once a month, or that they don't like a side effect from methadone, or they're limited in, you know, how many takeaways they can get or whatever else. And so I think this just emphasizes that really when we try and force the issue with the patient, I think it can be very challenging. I don't know what other people have experienced out there, and I'm always interested to hear if people have had similar experiences. But certainly where, you know, this is not the first time I've been consulted on a patient that's been on long-term stable methadone. They come into hospital, you know, and then put on another QT prolonging medication. They're hypokalemic from furosemide. And suddenly their QT is a bit lengthened, and then the team want to stop it or change things. And I don't know whether or not that's the right thing, because we do have to ultimately remember that methadone is a good treatment for opioid use disorder, and that patients, you know, if that's their preference, that they do, you know, you risk destabilizing that therapeutic relationship and forcing people to do things that they may not, and sort of leading to distrust in the medical system. I'm certainly aware of patients been being strong-armed into the depots and everything. So I think I did want to draw people's attention to that, and I think I think there's been some concerns coming from people in the New South Wales Users and Needs Association as well, that they've got some concerns that sort of thing going on with the depots and so forth. I saw a comment there from Wendy. We have some that are really keen to transition for freedom, and other that don't know what to do with themselves in that day, each day, and it's often the only. And absolutely, I've had a patient who he will go down in the statistics, in the research as a success, but then 3 months later he just found himself just so isolated. He enjoyed coming to the clinic each day, and look, that's not for me to say that that's I couldn't imagine anything worse personally than having to build your whole life around attending a clinic every day. But for some patients, they like that, and who am I to say that that's wrong? So yeah, I completely agree with that point. And then I saw Gillian's written a question: is the point of microdosing to find the gender? Yeah. So we will give I think probably a good opportunity to move on to the next case, because we're going to kind of look at a couple of different a case of a couple of different transfers. Are you happy if I move on, Dan, or do you want me to? Is there anything other questions from the chat that you wanted to?
Yeah, no, I'm happy to move on. Did anyone have any other comments, or feel free to unmute yourself?
I think there also might be a post presentation quiz again, just to sort of compare the before and after, whether people change their attitude.
I'll quickly launch that, and just let us know. It's the same question as before, but if you think you have the same answer as before, just enter that. Otherwise, if you think after this brief discussion, you might.
I didn't actually tell you what what ended up happening.
Oh yes, yeah.
So look, after everything, we made the decision to remain on methadone. We did trial the dose reduction down to 40 milligrams, and eventually, yes. So well done to the person who mentioned switching over to another antibiotic. I can't remember what it was off the top of my head, but they eventually stopped these things. Lo and behold, their QTC got better, and everybody stopped panicking. And I think that, as I say, like sometimes we just need to step back and look at the big picture. You've got a patient being monitored in intensive care with a slightly prolonged QT, and without any evidence of arrhythmias. If we can look at alternatives, certainly we can explore alternatives for opioid use disorder and support that. But at the same time, sometimes patients are fairly wedded to their opioid treatment. And so maybe we can look at just trying a gentle reduction or something like that.
Yes, yeah. Just while I'm sharing the results of that second
Everyone
poll.
still wants to transition it.
Yeah.
That's fine. That's fine. I understand. I hear what everybody's saying. Yeah, I think we're all putting our doctors and nurses and pharmacists and every other healthcare professional hats on there. I think I've probably got my patient advocacy hat on and sort of saying, well, we sometimes can guide our patients, but ultimately we explain the risks, and if that's what they want to do, we document and move forward. So anyway.
I think just very briefly as well, John from the chat has mentioned, the reality is in community practice, and, the main barrier indeed can be availability of dosing points.
Absolutely.
In some cases. And so this is definitely from the perspective of somewhere in inner city Sydney, and somewhere that has both, inpatient facilities as well as public dosing clinic as well, correct?
Yeah, and I really want to emphasize that I'm, blessed with resources, and I have tried one microdose in a community pharmacy, like outside, because this is independent of the trial. So she was someone from a telehealth consultation, and ultimately she ended up failing on it. But the pharmacy was, I rang the pharmacy and talked them through it, and they were very and this is in young in New South Wales, so a reasonably small regional centre, and they were very helpful. So it really can sometimes come down to what what your pharmacist is like and talking to them. But I'm sure there's people in the chats who've got far more experience with me, and certainly Simon Holliday is certainly a wealth of knowledge. He's been doing lots of community pharmacy-based transitions.
Yeah, there's a bit of chat there too about, having quite a lot of success transferring people from pharmacy. No big deal, and they can stay in touch with them. And also a community pharmacist's experience, as we said before.
Yeah, I'm just reading a couple of those comments there. Particularly, I'm interested to hear more about Steve's experiences as well. So and let us know your experiences. That always pleases me to hear that people are doing that. Yeah,
we could get Steve to unmute himself and give us a couple of words.
Steve, did you want to speak a little more about the pharmacy transitions that you've done? You don't have to. We're putting you on the spot there.
Yeah, on me, I've transitioned a few people. I simply prescribe a week's worth of microdosing at a time and give the patient a handout that says this much this day, this much this day. I use a 2-week protocol for no particularly good reason. I guess I was scared of a 1-week protocol, so I developed a 2-week protocol. And they just follow the protocol and they do fine. Yep.
And I know that, well, I'm pretty sure over in the ACT, Michael Levi has got a 2-week protocol going there as well. So you're not, and down in Victoria, David Jacker, I think his protocol is around 2 weeks as well. So, and I do want to emphasize, we made this protocol because we had to have a protocol. And that doesn't mean that we're right. That doesn't mean that others are wrong. It really was just a framework, and and it just happened to catch a light.
Could I just say that in the New South Wales Health QIT meeting last week, that they have flagged a 2-week limit to microdose transfer. I don't know why they did that. That wasn't discussed. They just did so. But this is a developing field. Everyone should keep talking about it.
Yeah, so I understand that they're looking at streamlining the process of getting the approvals, because basically I had to put in an application, so you get 2 approvals simultaneously, and I did that under the guise of a clinical trial, which was very helpful. And I believe they're now going to streamline the process of being able to have people on concomitant opioids, methadone and bupe, and also methadone and oxycodone, I think, for bridging. But I probably Nick Linceris and the team over at the Langton Centre have done more of that in the community setting, and probably better to talk about that. But yes, so I didn't realise they were going to put a 2-week limit on it though. That's interesting.
That would be
by the same. Could I just say that by the same token, I didn't realise that there was any problem with making an application. I've just sent an application in and written microdosing on it and had it approved without any fuss over the last 3 to 6 months.
That's great, because I as I say, I did do one for that, as I say, that patient that was outside the trial, but I still kind of, I won't lie, I lied and said they were in the trial. I used the same letter I use every time, basically. So I'm interested to hear that it's very easy to get that so quickly.
I had a fairly recent encounter trying to sort of not do a microdose transition, but try and get both approved at the same time through the approval authorities, and it was just too complicated. That was probably about 6 months ago. I basically would have had to rewrite what you wrote on your trial papers, and that was just too much work. So it will be great. This will be a great change if they can accept it as reasonable practice and approve it.
Someone's also asking, can Dr. Kelly please share his 2-week microdosing protocol? Yes, please, if you're happy to. Because it is to say this. I am a little nervous that yes, that the guidelines may not. I think that's probably one thing that the guidelines they should be looking at, maybe getting another couple of protocols going, but anyway.
Yeah. I mean, it's still not in the guidelines.
No, but it's rapidly approaching.
Yes, so we will wait anxiously for that.
All right. So look, one advantage that I do think microdosing does confer is it's a framework. It's a very clear pathway, and also if patients are going to experience withdrawal, it tends to, I'll talk a little bit about this later, but there tends to be a pretty clear pattern to it. So usually around day 5 or day 6, if they're on a higher dose. So day 5 on a lower dose, sort of under 80, day 6 on a higher dose, and then they do quite well after that. All right, so we decided you guys don't want to transition. No, that's fine. I would probably just try and reduce, but I probably wouldn't cease. I would probably keep it going. We'll move on. If everybody's happy.
We're halfway through our time and we're on our second case.
Oh, I'm sorry. Okay.
No, it's fine. We can always think of a way to go through the cases on the website if there's anything left over.
32-year-old on methadone. Now this person, he wants to transfer to depot. He's on 90 milligrams of methadone a day. He was also on mirtazapine. He also smoked about 1 gram a day of cannabis and some cigarettes as well. So what options in your location are available to transition to buprenorphine? I'm interested to hear what people's experience, what people can do. Are people able to? And as I say, I am very city-based, very metropolitan, but I do telehealth clinics in some of the more regional areas, and I'm increasingly seeing that this is very challenging. So I'm interested to hear what other options are available for people. Did anyone want to share? So you can. Dan's put up the poll there. Thank you. You only get one choice.
Where's the E option? No, none of the above.
None of the. Well, that's good to know. Not good. It's not good, but it's good to know that there's there's none of the above. Who is that? Or where are you? Or where are you from?
Gavin at Lithgow, and I'm the last standing late adopting community prescriber. There is nobody they go to the clinic or they go nowhere. People traveling from all over the Blue Mountains to see this chap, and he's retiring. So but none of these options are available to me. Mind you, I can't initiate these things, so I'm just carrying on other people's work. But there's no clear transition program available.
But that is a challenge, and good on you for sort of taking on as much as the slack as you could. So none of the above. Yep, I imagine any other none of the aboves want to sort of say option E and where they're from. I see Wendy in regional rural we are microdosing is outpatient. That's great. From mental health, I'm assuming that's mental health community liaison, I'm assuming. And
drug and alcohol on the Mid-North Coast, Chris.
Drug and alcohol on the Mid-North Coast. Fantastic. Well, that's great to hear. So look, in terms of options, while we're in order to move, okay, so we've got as an outpatient, undertake microdose transfer. Yep, okay. Some people got that about. As an outpatient, gradually reduce. Yep, so that's pretty common, and getting patients down. You know, and I don't know how people have gone with doing that. It can be challenging. Patients will sometimes destabilize a little bit. It can take a long time. They can get a bit frustrated. You know, but sometimes it goes well as well. As an outpatient, and then the other two options probably, you know, as an outpatient doing a transfer, probably on such a dose, probably the current guidelines suggest under 60 they should, you know, over 60, sorry, probably do it as an inpatient. And as to undertake microdose transfer from methadone to as an inpatient. So yeah, again, will depend. You know, some regional areas and even some more metropolitan areas won't have the capacity to bring patients in to do this. So again. Sorry, wrong way. So we decided, well, he actually, because he was part of the study, he wanted to just do it as quickly as possible, quick and dirty. But it did not go so well. And on day 2, he started complaining of some tooth pain. He asked for some analgesia and antibiotics. He became very aggressive and started yelling. He threw a chair at a wall, had a hole in the wall, apologized for the damage and decision to discharge the patient and trial an alternative. So about 5 months later, he came back and re-expressed a desire to transfer. And this time around, we said, well, we think we should try something different, given you've had a bit of a bad experience. And look, sometimes patients have had you know, bad experiences with being in hospitals, especially detox units that can sometimes feel a little bit like a prison, be a little bit triggering. And so patients don't want to come in. So he underwent a microdose transfer. So there's his progress. So he flew through. He absolutely flew. I'm not trying to sort of pat myself on the back here. I'm really want it. I'm really it was just thrilling because I was very nervous that, you know, he had a bad experience and that he was, you know, potentially going to decompensate, but actually, you know, minimal withdrawal symptoms, and he ended up on the 128 milligram depot after a month. Sorry, actually after he had that about a week after the study, and he was very happy and he ended up on that a while. There was a question there. When you say BD, what times are these doses given? So ideally 8 and 8. Often clinics or patients aren't there. You know, they not be open. So it's 9 and 9, or 10 and 10. But obviously that, you know, I don't tell anybody to stay up to midnight to take their medication. So ideally with a 12-hour gap, that will probably, again, not be something that's relevant in the future, because the Temgesic that we used in day 1 was off-label because technically, so 0.2, so buprenorphine comes in a number of different packages, so to speak. But in terms of tablet and sublingual forms, there's Suboxone, Subutex, and Temgesic. Suboxone and Subutex are TGA approved for opioid dependence, but Temgesic is actually TGA approved for pain. So in theory, what I was doing was off-label. And so probably moving forward, the recommendation has been to do 0.4 milligrams on day 1 because Temgesic just won't be available. And Steve saying, given the pharmacokinesis of buprenorphine, any gap works. And look, we've certainly had patients not that have had much smaller gaps than that because they haven't had their first dose of bup until, you know, 3 o'clock in the afternoon or something like that. So look, we've had plenty of patients, yeah, and we've had patients do 0.4 ultimately as well. So I don't know. Is it economic, not a, yeah, TGA approved is an economic, not a scientific measurability. This is very true. But I found out the hard way when I went down this road. So yes, this patient had 3 further Buvidal depots. He wanted to try coming off actually, and he's been off the Buvidal for about 3 months now. So he's probably still got a little bit of puke in his system, but not too much. We've kind of talked about this already.
Yeah, it's just there as a post poll to see if people change their mind after discussion.
Oh, okay.
But it's probably not so relevant because it's more about their local area, isn't it?
Yeah. I think it's more. I think it's more about what people can do rather than what they would do, because sometimes it does come down to availability. I
Should
see
we
John also.
Should we skip this poll just to save some time?
Yeah, I think
perhaps have a minute of
Yep.
discussion.
And John's just mentioned a quarter of a 2 million. Yeah. Look, we had also talked about using half of the 0.4 Subutex. Apparently they're not so great at splitting, but people do it. You end up with a bit of a 100 microgram, 300 microgram. I haven't done the 2 milligram strip trick. I imagine, given the regulations I face in a public hospital setting, I think I'd struggle with that one, but I'm not going to discourage you from doing from that in your own practices. Okay. Oh yes. So this is third case. This is pivoting slightly, but not. A 68-year-old female on methadone following hospital admission for ankle fracture. This is quite amusing, actually. This is a lovely little old lady. 68 is not that old, but she certainly was she was quite frail. She had some epilepsy, type 2 diabetes, hypertension, depression, and had been on methadone previously, but ceased. And then she'd been in hospital for this ankle fracture, and a friend had been sneaking in some methadone for her. So we sort of came along and said, well, would you like to do this in a more regulated and controlled fashion? To which she was amenable. So, I think showing, again, we don't like to be punitive out there in the world. We try and help support people. And she was on 20 milligrams, but then was very keen to get over to the Buprenorphine. She didn't want to, she didn't want to she didn't want to be picking up regular doses or anything like that through a pharmacy or anything like that. So she was very, very motivated to switch over. Okay, so yeah, quick poll. What do people want to do?
And you very well maybe option E as well as the last case.
Well,
so.
I probably should have had a look at this, because I don't think what we did is there. And people may want to put an option E. So please put an option E in the chat. Anybody else want to do anything differently?
Chris, so how long had she been taking the 20 milligrams of methadone?
About 2 weeks. About 2 weeks.
Okay.
Yeah, oh. Did you want to put up the results there? Dan?
Yep. Yeah, no worries. And in any case, Chris can share with us what he did.
Well, yeah, so as you can see, there's a bit of a spread, and that's probably because, yeah, she's on a low dose. She's got the world's her oyster in terms of transfer options. And also, as I say, what we actually, well, I will also add, this was not one of my patients. This was a patient that I was just aware of. So she was advised to skip a day. So it was actually happened to be Australia Day, so that worked kind of well. She attended the day after, and at that point, exhibiting basically no withdrawal symptoms whatsoever. She was given 4 milligrams of Suboxone, and 1 hour later, cows were actually 9 and her sows were 7, and she left the room to use the toilet. She reported she had some diarrhea, so it sounded like she sort of, it sounded to me like she'd had a case of precipitated withdrawal. So I was given the 16 milligrams of Buprenorphine, said, look, come back tomorrow, see how you're doing, and everything cows and sows had settled down quite a lot. So yeah, I appreciate that a cows and 9 is not massive, but a jump, we tend to sort of say a jump by 6 within 6 hours of cows is one of the criteria by which we would facilitate a withdrawal. But nonetheless, she got over to the 16 milligrams of the Buvidal and stayed on that. So I know we've got to be cautious talking about the TGA, as we've already talked about, but look, for patients on 30 milligrams or less, you can now do a straight switch as per the product information. And I've certainly done one or two that have gone pretty well. And I'm interested to hear other people's experiences, because I've heard, anecdotally of them sometimes not going as well. I think one thing I would like to emphasize perhaps with this case, and it came up for those people who are at IMEA as well, Nick and Sarah's talked a lot about this. We have this concept of the test dose. We've often used a test dose when we're switching people over, I'm not sure that, regardless of how we want to switch people over, I don't know if that's necessarily of clinical benefit. I'm certainly not sure. It's sort of like patients not in withdrawal, so let's give them a small dose to maybe put them in withdrawal. I'm not quite sure I understand the pharmacology and the psychology of it. And I've certainly seen a few people get the test dose and then get worse within about 2 or 3 hours. That's just my personal experience. As I say, like this is a more case-based webinar, so a little bit of an evidence-free zone on that one. Probably worth pointing out the pharmacological studies around the two medications. So on the left, you've got the sublingual. So you can see the peak effect really is within 1 to 2 hours in terms of plasma buprenorphine concentration. On the right, make sure you're looking at the scale. So that's time in days. So that's the 16 milligram, which is actually coincidentally what this lady received. And you can see that it's peaking. It's taking a lot longer to peak, and it's peaking around the 24-hour mark. Probably, it may well be a little bit earlier than that, but nonetheless, somewhere between 12 and 24 hours. So I think personally, if you're going to look at switching people straight over, certainly a day off would be recommended. I think then just go. I don't see the value of the test dose. I tend to agree with what Nick was saying in his presentations week before last. But happy to discuss or share thoughts on that one if anybody's got any other experiences. I thought I'd just mention also that we tend to do a lot of transfers. So this lady was given Suboxone. Naloxone sublingual bioavailability has been reported at between 10 and 25%. Now, it may well be a bit lower than that. The jury's still a little bit out on that one. But I just do think if we're doing these transitions, it's probably worthwhile to avoid the naloxone. I know that Suboxone has become ingrained into the guidelines and treatments, and there's the convenience of the fact that they can just take it and that's it. It's dissolved within seconds, as opposed to the tablets that take some time. But I think if there's that potential of absorbing a bit of naloxone in the process of switching over from methadone and bupe, I think it's best avoided personally. So I don't really have the option as to what I would probably do again here, Dan. Sorry, I probably should have had a look.
No, that's all good. And we can skip this poll just so we stay on time if you like.
Yeah, no worries.
Yeah. Did anyone have any thoughts or comments on that previous case? Or are we happy to quickly move on to the next one?
And this will be we've got 8 minutes till 7 p.m.
Okay.
So
this is probably one of the messier ones. So I'll try to move quickly. So we've got a 47-year-old referred for transfer by community prescriber. I think there was some concerns around methadone and alprazolam. And they had a history of metabolic syndrome secondary to quetiapine, complex PTSD, depression, anxiety, and was on 2 milligrams TDS of alprazolam. I thought it was interesting that in spite of having metabolic syndrome secondary to quetiapine, they were still on it, and then taking metformin in order to manage the metabolic syndrome. So that classic pharmaceutical cascade that can sometimes occur, and then methadone 35 milligrams daily. He said he drank about 4 standard drinks a day, didn't identify this as problematic. He's on about 6 milligrams a day of alprazolam as mentioned, but denied aberrant use. Safe switch was consistent with that. He was on methadone 35 milligrams a day for opioid previous independence, and he had previous difficulties, but he wanted to try an outpatient transfer in order to outpatient microdose. I put an asterisk there because I think, well, I think perhaps it that may have been under slight duress, and we'll talk about that in a moment. His UDS actually did, well, it's obviously positive for benzos and methadone, but it actually also did have opiates, but it wasn't described, that had not been disclosed to me, or he hadn't mentioned to me or anybody else. So he underwent fairly standard regimen transfer. As you can see, his sows were certainly a lot higher, his cows higher as well, and he certainly didn't do as well as our last chap. But after he had the depot, this is when things really started to unravel. So he started to report low mood, thoughts of worthlessness and hopelessness. He actually then started using extra alprazolam. He had a big bender on day 3, so using some shrooms and injecting some methadone, increasing his alprazolam, and then he started using heroin. And then he started using heroin every second day, so about 4 points IV, some cocaine, cannabis, and had escalating alcohol intake. So eventually, he went back to methadone. He was reinitiated as per the New South Wales guidelines. He returned to 65 milligrams a day and reported he'd been stable on that. But then, as a bit of a postscript to this chap, so he was re-referred to the service around his alprazolam use. And the GP certainly felt he needed to reduce this. The patient was very resistant. There were concerns that he was using other illicit benzodiazepines on top, and then he was minimizing his alcohol intake, and that he had multiple neuroleptic medications. And then he was also he was microdosing something else, which was psilocybin for PTSD. So again, interesting that he was very quick to get on that bandwagon. Not saying that bandwagon is wrong or right. And so he actually saw a different doctor. He didn't see me on this occasion, and was given the options of an inpatient transfer to Diaz with a slow weed, an outpatient alprazolam taper, or an outpatient diazepam transfer. And you know, I can see from the notes that he saw a very thorough clinician who really spent a lot of time with this patient, and they eventually opted for the third option. But then they've subsequently now requested a second opinion for the ongoing alprazolam, because they feel that it's still a benefit for them. And as of actually writing this up, they're currently awaiting that second opinion. So what was I going to say? Some take homes, I think, from that case. Well, firstly, we have been trying to look at some things in the study, and we will be hopefully presenting some data at some point around what potentially might be a predictor of success, and whether or not there are things that will predict whether or not a patient will have an easy transfer or a tough transfer. Probably those don't. So K10s, craving scores, and the dose don't actually seem to be predictive so far. As I say, this is all very early and not yet at the point where it's even close to publishable, or for peer review or anything like that. So there's still a lot of work to be done. There are some small signals that may be, in particular, probably benzos and withdrawal expectations may have some predictive element to them. So if they're on, a reasonable dose of benzos to begin with. The withdrawal expectations is something I asked every patient before they did their transfer. how difficult do you expect this to be? And actually those who thought it was going to be hard did better, which probably to me suggests that if the patient wants to do it, that they're committed to doing it, they've got a reason to do it, maybe travel on the depot or something like that. And so that's potentially predictive. So this slide is perhaps a bit less relevant without that. We took our case out at the last minute, but just demonstrating across the study, this day 7, which is actually, I should point out, that's representative really of what happens on day 6, because we're capturing that data a day late. So probably at the 16 milligram is when they start to really feel it. They don't really experience, most patients don't experience that much on the first 5 days. Perhaps they may experience a little more when a bit earlier when they're on lower doses. So the graph looks a bit different for those who are on under sort of 40 milligrams. Okie dokie. So look, this is all case-based, and this is really going off my experiences in the study and a little bit of out of the study. My personal experience is taught me that I think we should wait until the patient is ready to transfer. I think I haven't yet come across a situation where I've absolutely had to force a person onto Bup yet. I'm not saying that that doesn't happen, and I'm not saying that it can't happen, and I'm not saying that what people do in their practice is, it's all individual. But we've usually found another way. I certainly think managing concomitant substance use first is probably beneficial. Most patients that had a smooth transfer didn't, seem to be reasonably stable. Remember that most techniques have around 70 to 80% success rate. So as I say, what I'm doing here is not groundbreaking, or what I've done here is not groundbreaking. And there's bridging, there's stop and start techniques, there's people using patches, there's people doing all sorts of things. So I don't think we should be as scared of this as we are. Probably for microdosing, probably because anything under 60 and the patient may want to just do a straight swap. Anything under 30, they can go probably straight to the depot. Probably this is probably at the 60 to 100 marks, probably a sweet spot. I think that's where just from experience, those patients tend to do really well. Test doses, I don't know if they're a benefit for the depots. I'm not sure they're a benefit in general. I again leave that to your own clinical discretion. I think we should probably be using Subutex really for these transfers when we're going to, especially microdose transfers. We should use supportive medication. So we used clonidine and ondansetron in our study. I think it was good to just show the patient that they had something there if they needed it. I certainly did use some diazepam intermittently to sort of help if they had some, if they were particularly struggling. But I've tried to limit that and to a few tablets and controlled supply and everything else. And of course, talk to the patients in advance around what they can expect. Probably around day 5 or day 6 is when they will start to feel something. And look, moving forward, I'm sure there'll be a number of different publications that people will put out about their ways that they've transferred. There's a lot in the literature with all sorts of different techniques. And as I say, I can't say that what I'm doing is the be all and end all. It is a framework, and certainly if people feel more comfortable using 2-week transfers or using other techniques, I think my technique is good, but I think there's also, I'm sure that there'll be more modifications to come down the track. So I hope, of course, if you want to get specialist advice, you can call your local AOD service, or you can ring DASIS. This feels a bit like a plug for myself because I work for DASIS, but nonetheless, you are welcome to call us. We're all very friendly there. Happy to answer questions. It's probably 7 o'clock. I imagine people are keen to go and have dinner.
Yes, we'll let everyone go.
What's the latest episode of The Last of Us? Whatever it is you want to do.
And thanks very much, everyone, for coming. And I just put something in the chat. We're always looking for ideas about topics for these case-based webinars. Any examples of patients in your practice or scenarios that you think might help people, working with opioid treatment? We'd really appreciate any ideas. So please email Daniel to give him your suggestions.